Welcome. I'm Courtney Schreiber, part of your medical team here at Littleton Radiation Oncology. It is our sincere desire to provide you with the most efficient, state-of-the-art, and caring environment in which to undergo your prostate therapy. We invite you to tour our facility, and in a moment, Dr. Schreiber will provide you with some important information about prostate cancer and how we treat it here at Littleton Radiation Oncology. We hope you'll find this presentation informative, and we will gladly answer any further questions you might have regarding cancer and your individual treatment plan.
Hello, I'm Dr. David Schreiber, and welcome to Littleton Radiation Oncology. Today we're going to talk about the diagnosis, staging, and treatment of prostate cancer as we do it here at Littleton Radiation Oncology. First, I'd like to go through the diagnosis of prostate cancer and how we make that diagnosis. Chances are you've seen a urologist, and at their office they performed an ultrasound and a biopsy procedure. You most likely have also had a PSA blood test performed. We use the information obtained at the urologist's office to help us decide what stage of prostate cancer you actually are. For instance, the PSA level can be anywhere from close to 0 to a very high level, meaning over 20 or even 30. But we do use the different levels of PSA to help differentiate your exact stage. We also use the results of the biopsy to help us. Your biopsy is given to you in the form of a Gleason score. The Gleason score can range from 2 through 10. This is how the cancer looks under the microscope to the pathologist. Actually, the pathologist sees a grade of cancer under the microscope, and he grades this cancer from 1 to 5. 5 is the most aggressive. Oftentimes, they see more than one grade in the specimen, and they will add up the two numbers of grades to get the total score. So a Gleason score of 2 would be your lowest score and the most benign type of cancer, and a Gleason 10 would be the highest score and the most aggressive kind of cancer. So we combine the PSA value and the Gleason score to get risk categories to place you in and help determine what type of treatment that you're going to have. You may have also had some other staging studies to determine if the disease has spread to other parts of your body. These could include a bone scan, a CAT scan, or possible a combination of the two called a sodium fluoride PET-CT, which actually combines the benefits of a CAT scan and a bone scan in just one study. However, this study is relatively expensive, and a lot of times insurances will not pay to have that combined study done to begin with. Once you have the staging studies done, or perhaps I will order them from this office if they have not been done, then we can talk about placing you in specific risk categories and determine the proper treatment for you. We basically now have 4 risk categories for prostate cancer. These include very low risk, intermediate risk, and high risk disease. These risk categories have been more recently defined. Prior to recent times, we only differentiated prostate cancer into 3 categories: low risk, intermediate, and high risk. But more recently, a new category, the very low risk, has been defined. The very low risk category is someone that has a Gleason score of 6 or lower, a PSA density of 15% or less, and this translates into around a PSA of approximately 4.5 for the average size prostate gland, and 2 or less biopsies positive, with less than 50% of the biopsy having cancer within it. This type of category, this very low risk category, has been shown to be very indolent, and many people do not even have therapy for this very low risk disease. It doesn't mean that you don't need therapy for very low risk disease, but it means you should consider therapy very carefully and weigh the risks of the therapy versus the benefits of the therapy in actually curing you. But definitely treatment is recommended for low risk, intermediate, and high risk disease. Low risk disease is defined as a Gleason score of 6 or less and a PSA of 10 or less. Intermediate risk is defined as disease typically with a PSA value of between 10 and 20 and a Gleason score of 10 or higher. However, an intermediate risk category can also be defined as a PSA between 10 and 20 or a Gleason score of 7 or higher. So it varies from individual to individual, and we take other things into account, like how many biopsies are positive, how aggressive the cancer looks, whether it's a 7 or a high risk 7 or an 8 or 9. And then the final category is the high risk category. This category is someone with a PSA of 20 or higher and a Gleason score of 8 or higher. So when you have these types of categories, we can determine the treatment that's most appropriate for you. The chance of picking up evidence of distant spread of the disease is minimal if the PSA is greater than 10, and typically we will not order any staging studies to look for spread of the disease if your PSA is below 10. These staging studies, as are previously mentioned, CAT scans, bone scans, and sodium fluoride PET-CTs. Now I would like to talk about how we manage the various risk categories of prostate cancer in this office. Low-risk patients are typically managed with radiation seed implants alone, and the isotope that we use in this office is palladium-103. The intermediate-risk patients can be handled with either the combination of external beam radiation and seed implant, or seed implant alone with a newer seed called cesium-131, which has a broader range of coverage and is able to cover those areas at risk outside the prostate that are so typical in an intermediate-risk patient. High-risk patients are handled always with the combination of seed implant and external beam radiation, with the seed used being palladium because it has a very narrow area of influence. Palladium seeds give a very intense dose of radiation to the prostate and almost zero dose to the surrounding tissue, whereas cesium seeds, as I previously mentioned, tend to give an excellent dose to the prostate gland, but in addition give a nice dose to the surrounding tissue within approximately 1 to 2 centimeters of the gland, and that's the area that's at risk with the intermediate risk patient. Lymph node risk is really not an issue with intermediate and low risk patients because those chances are below 1%. Whereas with high-risk patients, your chance of lymph node involvement can be 10 to 20% or even higher, and therefore we have to cover those lymph nodes with a broader range of radiation management. The external beam radiation that we use in this office is called IMRT, or intensity modulated radiation. All IMRT treatments are given with image guidance, and we use CT scan for image guidance as well as fiducial markers for CT guidance. Some patients, because of health issues or by choice, are not candidate for seed implants, and they are treated with external beam radiation alone. At this point, I would like to describe how we go through the process of treating a patient with external beam radiation. The process begins with a planning day, and on this day, you are taken to 2 locations. One is my surgery center, which is located just across the parking lot from our office, and in that location, under a general anesthetic and a 10-minute sleep time approximately, we will place 3 small markers within your prostate gland. These markers are not radioactive, and they help us localize your prostate each day under treatment. After you wake up from this very short procedure, we walk you across the parking lot to our main facility to the CAT scanner, where we do a CAT scan of your prostate gland with those markers in place. We also put a little bit of liquid dye in your urethra without a tube so we can visualize the bottom and the top part of your prostate gland on that CT scan. Finally, on that day, we do an ultrasound, but that ultrasound is done while you're asleep at the surgery center to help us guide the process of putting those markers within your prostate gland. After that day is complete, you will be given a choice of treatment times. You'll pick one that's right for you, and that's your same time every day for treatment. It usually takes us about 1 to 2 weeks after the planning date to get all our computer work and calculations in order so we can give a precise treatment based on the computer work that we've done. You should also know that on that planning day on the CAT scanner, we not only put the dye in the penis, but we also make some small marks on you that day with a marking pen. They look like little freckles, and they're permanent. We call those tattoos. Those help us line you up in the same position each day using our laser beam. This planning process is the same if you're having external beam radiation as the only treatment for your disease, which would be about a 9-week course, or if you're having external beam radiation for a shorter course, which is a 5-week course if we're combining it with a seed implant. When you return to the clinic approximately 1 to 2 weeks later, your first day on our regular treatment machine, our large linear accelerator, is just a picture-taking day to verify all the computer work that were done. Then on the following day, we'll start in with the radiation treatments. Now the radiation treatments are painless, daily treatments. They're Monday through Friday, 5 days a week, only a few minutes a day. In fact, your total time in this office each day is approximately 20 minutes, and that's from coming in the door to going back out of the door. Most of your time is spent positioning yourself accurately on the table on the linear accelerator so that we can get the exact alignment necessary to treat you precisely. Our beams are very precise here. They are accurate to within 1 millimeter. That's why we have to follow your prostate and your body motion every single day that you come in, because these can vary by 2 or 3 millimeters in a day. So we want to make sure that we compensate for that movement. That way our beams can enjoy the accuracy that we have. We use very technologically advanced treatment planning systems here so that we can precisely determine the dose necessary to treat your prostate gland based on its shape and size and even the location of the cancer within the prostate gland. Once you begin treatment, even though you're visiting our facility 5 days a week, Monday through Friday, you will routinely see me 1 day a week, generally on Mondays, or my partner if I'm not available, to see how you're doing, and you'll see an oncology nurse another day during the week, typically on Fridays, to see how things are going. Of course, you'll see your friendly therapist every day when you come in for treatment, and they can answer some of your basic questions as well. But when we do see you, we're going to ask if you're having any side effects from the radiation, and side effects are related to where we aim the beam. In the case of prostate cancer, we're aiming the beam in the pelvic region, which is below your abdomen. So that's the only place you should experience side effects. In other words, we don't expect you to lose hair from this kind of treatment. We don't expect you to get a cough or chest pain or shortness of breath or even nausea from this type of treatment. It's below all those structures. But what is possible is some diarrhea, some burning urine or increasing frequency of urination, or perhaps some anal irritation. Red skin is extremely rare because we use deeply penetrating beams, and hair loss in the pelvic region is also very unlikely to occur. Those side effects I just mentioned are short-term, treatable, and reversible side effects. They're gradual in onset, taking about 2 weeks to notice, and they gradually go away after we're done, taking about a month to go away. The long-term risk of external beam radiation is extremely rare but possible. One long-term risk is chronic bladder irritation. That's an occasional blood clot that comes out through the urine. It can happen 6 months to a year or even 2 years after we're done. It is treatable and will eventually reverse itself. Another long-term risk is chronic diarrhea. That has less than a 2% chance of happening as well. Chronic diarrhea means diarrhea that lasts for many months before it goes away. There's a small but definite risk of chronic anal irritation. We rarely see that with the external beam radiation. Finally, there's a risk of impotency. Impotency is defined as the inability to obtain an erection long enough to allow penetration for sex. This risk is approximately 30 to 40% with external beam radiation. The good news about impotency caused by any radiation management is that it is very treatable, and in fact, Viagra and other medications similar to Viagra have about an 80% chance of helping you through this side effect of the treatment. You may have heard about incontinence, leaking urine. Incontinence is not a risk of external beam radiation. Now I would like to talk about prostate radioactive seed implants. Another term for this is brachytherapy. This is defined as the implantation of radioisotope within a structure of risk. In this case, it's your prostate gland. The seeds that we use, as I mentioned before, are either palladium-103 or cesium-131. Palladium-103 is a seed that we use for the low-risk patients or the high-risk patients when it's combined with external beam, or the intermediate-risk patients when it's combined with external beam radiation. There is a large subset of intermediate patients, however, that can benefit from the cesium implant, and this negates the need for external beam radiation for those intermediate-risk patients. This actually opens up a whole new world and possibility for patients of intermediate risk that have been reluctant to come to our facility because they come from long distances and they really don't have the time or resources to undergo external beam radiation management. So now I would like to talk to you about how we actually perform the seed implant through our facility. On the day of the procedure, I will meet you and your urologist will meet you over at our surgery center across the parking lot. On that day, you will arrive about 1 to 1.5 hours early to be prepared for your general anesthetic. Once you're asleep, we will lie you on your back on the operating room table, place your legs up in stirrups again, just like we did with the pre-plan, and also introduce the ultrasound transducer into your rectum to visualize your prostate gland. During the actual procedure, we will attach a template similar to the template here onto the ultrasound transducer so we can guide our needles into the prostate gland as per the ultrasound pre-plan. The needles that we use fit into the holes of the template like this in a predetermined pattern by the pre-plan. They're just hollow steel needles. They don't have any radioactivity within them. Once all the needles are in place, then I will insert radioactive seeds or pellets in through those needles into your prostate gland using ultrascopic as well as fluoroscopic guidance. I have created a device called the Instant device that actually creates stranding of the seeds on the fly in the operating room so we can customize your seed implant precisely to your prostate gland as it appears that day. Don't forget, on the pre-planned day, we are estimating the number of seeds that we're going to use and number of needles. On the actual procedure day, we are being very, very precise because things can change actually within the operating room. Your prostate can swell, it can move, it can bleed. All kinds of things that are kind of unpredictable can occur in the operating room, and we need to be able to adjust to those unpredictable moments. The actual procedure only lasts about 30 to 45 minutes, even though you're asleep for about 1 hour. Approximately 1 to 2 hours after you wake up, you will be allowed to leave the surgery center after you demonstrate the ability to be able to walk and ambulate on your own, as well as urinate and hold down some type of nourishment. Before you leave, and you'll probably feel pretty darn good before you leave because it's not a very difficult procedure, it's not a very painful procedure, you will still be required to have a ride home that day because of the anesthesia that you've had. After you get home, we do ask you to take it easy for a couple of days and then resume normal activity. After approximately 1 week, you can resume strenuous activity. This includes heavy lifting or exercising. Finally, there are some small radiation precautions we would like you to follow for approximately 6 weeks after the procedure. This includes no prolonged contact on your pelvic region and the lower part of your abdomen by another human being. This is because there's a very minimal amount of radiation that can still be detected on this part of your body. This means we would not like to have any small children on your lap or allow any spooning or sexual activity for approximately 6 weeks after the procedure. Everything else is fine. This includes sitting next to pregnant women or other human beings, or sleeping next to whomever you please, or traveling on a plane with someone next to you. All of these are completely fine. By the way, when you're at the airport, we will give you a card to keep in your wallet that says you're radioactive, and that's valid for approximately 3 to 4 months after the procedure. Even though we wouldn't be able to pick it up by a normal Geiger counter and it's perfectly safe, some of the international airports do have sensitive radiation detectors, and I've had patients tell me that they have been detected in other foreign countries and they get swarmed. We would like you to return for follow-up after this procedure, beginning approximately 1 week afterwards. This 1 week checkup is very important. At that checkup, I'm going to check your skin to make sure the little needle holes have healed up adequately, and I'm also going to perform a CT scan to determine the position of the seeds within your prostate gland so we can determine a dose distribution and evaluate the quality of the implant. 99% of the time we think it's fine and there's no further treatment or intervention required. However, those 1% of patients could require some additional management, and we have to know about that, and that's why we do that CT scan. We don't see you again for approximately 7 weeks. At that time, I will perform a rectal exam and I will perform a PSA blood test to give you an idea of your progress. After that, we generally alternate follow-ups with your urologist, so you're seen about every 3 months for the first 2 years, then every 6 months until 5 years, then about once a year thereafter until absolutely 10 years after your procedure. It's very rare to recur after 5 years, maybe less than 1%. However, I like to keep tabs on my patient anyway because sometimes other issues develop between 5 and 10 years. We like to stay in the loop. With each and every follow-up, we will perform a PSA blood test and do a rectal examination. And that's all we really need to do to monitor your progress. Don't forget, the PSA can go up if your prostate cancer returns not only within your prostate gland, but anywhere in your body. So if that PSA stays nice and low, we're very confident that there is no disease active elsewhere in your bones or your lymph nodes or anywhere else. If the PSA goes up, yes, we have to look at the pattern of that rise and determine if it's necessary to do any further staging workup to determine if it's locally recurring or if it's spreading or both. At this point, you may be wondering, after all of this therapy, what kind of results can I expect as far as cure of this disease? The good news is prostate cancer, when caught early and localized or even regionally localized, tends to have a very good cure rate with the type of treatments I've already outlined for you today. For instance, our low-risk patients tend to enjoy a 15-year disease-free survival of approximately 96%. Our intermediate risk patients tend to enjoy a survival of approximately 90 to 95% over that same time period. Even our high-risk patients tend to enjoy a survival rate of approximately 80 to 90% at 15 years disease-free. Again, thank you for visiting us at Littleton Radiation Oncology today. I hope you have found this video informative. If you have any questions, please do not hesitate to ask me or any of my friendly staff, and they will be happy to assist you. Thanks for watching.